called shower days, and they use that as their dedicated skin round to really investigate and check the patient. And not only that, it's also part of our assessment, our daily assessment. When you go in and say hi to the patient, you're looking at that patient's skin while you're doing that. Every interaction you have that patient, you're looking at their skin. You have to make that a priority.
Hey out there, welcome back to the Nursing Home Abuse Podcast. My name is Rob. I will be your host for this episode. Today we're talking about the link between incontinence of a resident and how it affects wound development and skin integrity. But we're not having that conversation alone. We have the fantastic Jessica Tonia. It took me a little while. I had to phonetically, spell that out. But it's Jessica Tonia, registered nurse, with us today to talk about that link between continence care and wound development. But before we get into that, it's time for the nursing home regulation question of the week and another opportunity for you to listen to me beg for you to enter the contest to win this mug, the Nursing Home Abuse Podcast coffee mug. It's perfect for whatever drink that you choose in the morning time or whenever, or you don't have to drink from it. Put put hard candy in it and put it on your coffee table. Put buttons and loose pins and things in it, whatever you want. It serves any function. But your chance to win it officially is to go to TikTok at Justice for Residents, find the question of the week video. It's going to be the thumbnail that has a cup of coffee on it. Then you're going to answer the question and you're going to post your favorite morning drink. It doesn't have to be coffee. It can be hot tea. It can be Coors Light, whatever you want. Post that in the comment. One lucky winner will be randomly chosen and announced on Sunday on TikTok and at shinkfirm.com/podcast/giveaway. But again, who are we kidding? Not even the Dirty Dozen is entering this thing. So at the end of the year, it's going to be 2 boxes going to Goodwill of coffee mugs. But don't let that happen. Get your coffee mug. Prizes ship at the end of the month. Time for the question. All right. So difficulty for the question this week, I'm going to say is medium. Under 42 CFR 483.30B, what is a physician required to do each visit? Is it A, speak with the nursing staff regarding the current care plan, B, write and sign a progress note, or C, speak with the resident's family regarding current treatment? And that answer is B, write and sign a progress note. Technically, the physician is not required to speak with anybody. The physician can review the chart and render any care that the physician thinks is appropriate. But the only thing that they're required to do here is write and sign that progress note. All right, folks, now it's time for the meat and potatoes of the episode. As I mentioned, we're talking about incontinence and wound care and wound development. We're not doing that alone. Today we have Jessica Tonia, a board-certified family nurse practitioner with a rich background in emergency, critical care, and forensic nursing. Before becoming a nurse, she spent years in biotech, purifying monoclonal antibodies. Jessica was a frontline ER nurse during the COVID-19 pandemic and recently earned her MSN with a focus in family practice. She brings sharp clinical eyes and legal lenses to healthcare, and we're so happy to have her on the show. Jessica, welcome to the show.
Thank you. How are you doing today?
I'm rocking and rolling. Can't complain. Thank you. So we've had a lot of shows about pressure injuries, wounds, that kind of thing, but I don't think we've had one dedicated specifically to how continent care affects the development of wounds and the healing of wounds. So let's start from just the basics, Jessica. What does incontinence have to do with how the skin breaks down at all?
So incontinence is basically when a patient, they're either bowel, we have it called like bowel or bladder incontinence, they're not able to hold in their urine or feces. It could be both, could be one or the other, depending on their condition. Sometimes you see this a lot when a patient gets older, like they have dementia, they become bedbound, and that's where the incontinence comes in. So what happens is when you're not able to control your bowels and bladder, it gets released sort of spontaneously. And then when it leaks, it kind of just you have no control. So it just kind of leaked all over you. And unfortunately, because of the material, it's extra moisture. And also, we don't really think of it, but feces and urine, it's actually acidic. It goes against the skin. So when it goes against the skin with that extra moisture, it really causes a lot of irritation. We set them up for pressure injury that we see. It's really hard to control the wound. It leads more likely to develop wound to form.
So moisture is the problem, and
Mhm.
specifically moisture from either the feces or the urine is even more of a problem because of the
Mhm.
acidic nature of it, and it kind of breaks the skin
Yeah.
down itself.
Yes, it does. It breaks down the skin, and if you had a wound or you have something that's developing, like for example, a sacrum, like you had like a stage one pressure in the sacrum area, which is commonly can cause incontinence there, that's just gonna make things worse. It's just gonna open up. Eventually, the skin gets fragile and it opens up, and then now you have a possibly stage two, even leading all the way down to stage four if it's not monitored correctly.
So let's take the but again, let's say that we have a resident that might be both bowel and bladder incontinent. Okay,
Mhm.
um, what are some of the best practices to keep that the sacral area dry, like and kind
It's
of not
gonna be
exposed to it?
Yeah, you have to be really proactive. It's really monitoring if depending on the patient, if they're mobile, like they can get out of bed, you want them to keep on moving because all that moving kind of chips that fluid and keep the skin elastic. So that help if they're bed bound, you have to turn them every 2 hours. You may have to look at devices like special mattresses. They have like little like air pump that actually move the pressure point off the body. You just don't want to over the skin over the bone. That's where the pressure injury can develop. You can look into like lifting the pillows to sort of lift. Like there's one of the saying that we always say in nursing, is float your heels, meaning you put a pillow on the person's heel, and that's where the pressure injury can form there. So you want to look at the device, you keep them clean, keep the sheet clean, just a lot of cleanliness and making sure that everything's working and it's being proactive.
How about the the idea of absorbent products? Like when should we be using those as opposed to some other intervention for incontinent residents?
If you can use them, you can, especially if they're mobile. Like you can use like a Depend product, but you have to make sure they're clean every time they go to the bathroom. And you want to really take them off. You don't want to leave them in. If they have an incontinent, you have to make sure they're clean and replace it with clean, dry one.
It's interesting you mentioned that mobility and like keeping somebody moving, even if they're
Mhm.
wet, kind of might help prevent a wound from developing.
Right. Because that movement kind of like it lets the body sort of shift its fluid. It can move the fluid so that way, if you move around, it shifts the fluid, so you're more likely to expel the fluid. It also kind of keeps the skin kind of loose and laxed a little bit, so it kind of can recover quickly. So that's why we always want to move. It's also the same reason why we always want to move to prevent blood clot from forming as well. So movement is good. If we can try to keep the patient mobile and changing position, the better.
Tell me about the difference, if any, between the a moisture associated skin damage and a pressure injury, if there are any differences.
There are a couple differences. Usually, the moisture is usually in. It's usually involved like where it's mostly resolved around the peritoneum, like the genital area. You're mostly gonna see it in the butt, genital. You might see it a little bit down like the leg there because the way gravity is. Pressure injury it's really form over the bone. Anytime you have bony prominence, like heels had bone and they have skin. That's where they can form.
So I guess you could have moisture associated skin damage at a pressure point that develops into a pressure injury.
It could, but that can be really hard to tell. Like it could be a lot of factors involved. Um, so it's possible that way.
So what are some of the common challenges that a nurse faces in long term care with incontinent residents and wound care?
A lot of it is just um staffing, I think staffing and supply and time management. If you have to be really vigilant, that's like, and knowing who your patient are they able to get out of bed? If they're bed bound, now we have to make sure they're on a 2 hour cycle, make sure the sheets are clean or in the right mattress, or you have the right absorbent product, skin barrier. You have to make sure all that. And you have to make sure you can be able to delegate that to a nursing assistant. Unfortunately, we are facing a shortage in long-term care facility where they don't always have that. The nurses are doing everything, and that tends to put a strain on the care. So it's a lot of like teamwork and working together, and having the right supply and even like policy to help enforce that in place.
Tell me about perhaps some of the factors that go into whether or not you would use absorbent products on a resident versus not. Like who qualifies for it and who probably shouldn't have them.
I'm trying to think. I think one of the things I would think about is patients that have sensitive skin. They have they're prone to developing eczema or sensitive skin. You may be careful with an absorbent product, or you might have to find a special absorbent product for that skin type. Everybody has different skin type, and there are special absorbent for different type of skin type that might have it. If they're using a certain brand, that's one thing you have to make sure. Are they developing something like a rash because of that? Then you have to think about getting a specialized product for that patient.
So would it be fair to say that the default for any resident that's incontinent of bowel and bladder is to be vigilant for pressure injuries to the sacral area or to the buttocks?
I mean, yeah, they can be vigilant. It's kind of hard to be vigilant too. I mean, how do you look? You need somebody to kind of help monitor that too. Like it's kind of hard to look at your backside, but they should be vigilant if they can. If they're mobile and they understand and they know how to clean, they should be teach and educated how to do it.
So how can nurses kind of spot the early signs of skin damage that comes from incontinent residents?
So it depends on a lot of times it depends on the policy of their facility. They'll have you can have skin round, dedicated skin round that would come to each patient once a week to see, or once a day. You can have, I know in some nursing home, they have what's called shower days, and they use that at their dedicated skin round to really investigate and check the patient. And not only that, it's also part of our assessment, our daily assessment. When you go in and say hi to the patient, you're looking at that patient's skin while you're doing that. If every interaction you have that patient, you're looking at their skin. You have to make that a priority.
What is a skin barrier in terms of continent care?
So a skin barrier kind of helps, it's like a cream that kind of help moisturize and kind of provide that extra protection between whatever the surface is and the body. So it's kind of like a extra layer of protection for the skin. It provides what it needs, like moisturizer and protection that it needs, and it's sort of help reduce the chance. But again, it also it depends how often you're applying it, how you're doing it, how it works.
As a layperson, as a non-clinician, it seems like almost like a I don't know, like a oxymoron or like kind of like a strange thing to say that moisture is bad, but we're going to put a moisturizer on your body. So explain that. Like, how is it that moisture typically is bad, but this skin barrier is okay?
Moisturizer, it gives more moisture than we really need. The skin just needs the right balance, and unfortunately, it can be very finicky at times. Mm-hmm. And everybody's skin is different. I mean, I have sensitive skin. I need a little bit more to keep my body hydrated. Mm-hmm. Other people may not. So it really depends on the product and the product that you're using and how often you use it. Some people need it once a day. Maybe they need a fraction. Some people need a little more. Mm-hmm. So it's about knowing you have to know yourself. You have to know what you are. And if you're not sure, you can see a dermatologist to see how they can investigate. They can figure out the right product for you.
Sure. Okay. So, I mean, what role does advocacy on behalf of the resident and the resident's family mean in this situation? Like, what can people do?
Well, Well, people, it's big part of it is education. We're nurses, we have to educate everybody. You educate the resident how to keep clean, how to do product and moisturizer. You educate the family. Sometimes patient doesn't know what to do. You have to educate the family to be vigilant as well. And this is anywhere, like anywhere, even a hospital setting, long-term care facility. You have to be your own advocate. And that's how nurses can help with that, to teach you how to do it, spot these things.
But I guess at the end of the day, if your loved one is incontinent of bowel or bladder and is perhaps, not necessarily bedbound, but relies on the nursing home staff for bed mobility, then that individual's at risk, and you want to be extra vigilant.
Yes, you want to be extra vigilant. You're gonna have to you have to speak up to them. You can be part of it too. Like, you can be part of the skin assessment with the nurse because you want to know. Well, ask questions, do whatever, be proactive.
Excellent advice. Well, Jessica, I really, really appreciate your time today and coming on the show and sharing your knowledge with us.
Oh, thank you so much. I appreciate being here. Thank you.
Well, folks, I hope you found this episode educational. If you have an idea for a topic that you would like for me to talk about, please let me know. If you have an idea for a guest that you would like for me to talk to, please let me know that as well. New episodes of the Nursing Home Abuse Podcast come out every single Monday. And once again, please do anything. Like, you could just yell out your window that you want a Nursing Home Abuse Podcast coffee mug, and you'll get one. It's going to fall from the sky. It's going to land in your hand. But I hope that I'm going to eventually get rid of these podcast coffee mugs from my house at some point. So please aid me in that process. And with that, folks, we'll see you next time. Thanks for tuning in to the Nursing Home Abuse Podcast. Nothing said on this podcast, either by the host or the guest, should be construed as legal or medical advice, nor is intended to create an attorney-client relationship between the host or their guest and the listener. New episodes for now are available every other Monday on Spotify, Apple Podcasts, or on your favorite podcast app, as well as on YouTube and our website, nursinghomeabusepodcast.com. Again, that's nursinghomeabusepodcast.com. See you next time.